Good morning. I'm Dr. Erika Hamilton. I lead the breast cancer research program at Sarah Cannon Research Institute in Nashville, Tennessee, and I join you on behalf of Komen of Central Tennessee today. So, today I want to talk to you a little bit about COVID 19 and cancer. And as cancer patients, survivors, or family and friends of loved ones, a little bit more about COVID 19 and what you can do to protect yourself. So, severe acute respiratory syndrome, coronavirus 2, or COVID 19 as we're all calling it, is a new virus itself. The first cases were identified in people with pneumonia in Wuhan, China in December of 2019. We really think that this virus started in animals and then subsequently spread to people. Despite COVID 19 being a new virus, coronaviruses are not new at all. In fact, coronaviruses are actually a very common virus that's responsible for the common cold that we all get and don't cause many problems. There have been more aggressive coronavirus variants similar to COVID 19 in the past. And on the left, you can see these were the SARS, MERS type viruses that caused quite a bit of problems. So this is not new to us. So, how is coronavirus spread? Most people are infected from other people. It spreads the same way as colds and flu through droplets that we create when we talk, when we cough, when we sneeze. Droplets in general only go through the air about 6 feet before they land. However, they can land and live on surfaces for days. So you've probably seen some stuff in the media about they live a different amount of time on different surfaces. So, for example, on paper or cardboard, we really think that they probably do not live longer than 24 to 48 hours. However, on surfaces like steel, they may live up to 5 days. People can get infected when these droplets enter the nose, the eyes, or the mouth. And this doesn't just have to be through the air if somebody's directly sneezing on you. This could be that they sneezed and touched a doorknob and the droplets were transferred to the doorknob. You touched the doorknob and then rubbed your nose. Some coronaviruses are also spread through feces. We think that COVID 19 is probably also likely to be spread through bodily fluid, but this is probably not how most people are encountering COVID 19. So, the symptoms, what are they? They really start like many other illnesses. They can start with fever. The majority of patients with COVID 19 have fever, but this is not universal. It's thought that about 80 or 85% of people with COVID 19 have fever, but I personally know of people that have had COVID 19 and not had fever. A lot of people describe this prodrome. It may be myalgias or body aches, like you're coming down with something. Sometimes people have sore throat, nasal congestion. Some people have GI symptoms, and the most prominent GI symptom has really been diarrhea. Later, a couple days into the illness is normally when the cough starts. A lot of patients have cough, shortness of breath. There's been one symptom that's been quite unique, and we've really just heard about it more recently, is anosmia or lack of smell. A lot of these patients report profound lack of smell, lack of taste with food as well. Symptoms can start anytime after exposure, really from 1 day up to 14 days after exposure, but we think probably what's most common is about days 4 to 7. Some people have very minimal symptoms, no symptoms. I think you've heard a lot about some children having no symptoms where you would not even know that they're sick, but they can still spread the virus to other people. Most people have a mild illness with COVID 19. We certainly are hearing about the patients that are hospitalized or critically ill, but these are the vast minority of people with COVID 19. However, sometimes it can be severe and even fatal. So, the diagnosis and treatment of COVID 19. Because the symptoms can really be similar to many other illnesses, we have to test via a nasopharyngeal swab, which is a little swab that goes into the way back of your nose and sent off for the testing. Mild symptoms can be treated with medicines such as acetaminophen at home to lower the fever and just good supportive care. If symptoms are more severe, shortness of breath, etc., then treatment in the hospital may be required. I'm sure you've heard a lot in the media about therapeutics for COVID 19, what drugs may work to prevent it, what drugs may work to treat it, and then also a lot about vaccines. So it's correct that we're looking at a lot of drugs right now, both drugs that are old and we have laying around, as well as new drugs. But currently, there is not any specific treatment that is recommended for COVID-19 and approved. There was lopinavir, ritonavir, which are actually antivirals that are used for HIV that were looked at. We're looking at hydroxychloroquine with or without azithromycin. Hydroxychloroquine is also known as Plaquenil. It's a drug that's often used for patients with rheumatoid arthritis. Azithromycin is a very common antibiotic. Tocilizumab is an IL-6 inhibitor. We actually use this in our cancer patients a lot for something called cytokine release syndrome, which is where the immune system gets very activated. This tocilizumab can turn off that activation of the immune system and can be helpful for people that have a lot of lung inflammation for this virus. We're also using something called convalescent plasma. This is a blood product, so somewhere where you would go almost like you were giving blood, but instead of taking out the red blood cells, they would take out the plasma that's filled full of these antibodies and proteins. And so convalescent plasma are from patients that have already had the virus and recovered, and those antibodies that help them recover are then given to another person to help that patient recover. And also vaccine. There's a number of vaccines that are in development, but as of right now, these are not available. The earliest projections, absolute earliest, is probably January or February of next year. We think that we probably will have one by summer, but probably what's most likely realistic is the spring of next year. So there's been a lot of talk in media about, well, maybe we should all just take these medicines. That's not the appropriate thing to do. We have all of these medicines in trials. These medicines come with significant side effects, some of them. They're not to be taken at home unmonitored. The first trial that we had with lopinavir and ritonavir, there was a lot of excitement about this, and it turned out the trial was completely negative. Those medicines did not help. So be cautious about what you hear in the media because sometimes a lot of this isn't really rooted in scientific truth and hasn't been through clinical trials yet. So what can you do to prevent this? And this is the age-old common things, but maintain good personal hygiene. Wash your hands frequently with soap and water. There was a lot of excitement about hand sanitizer and Lysol and Clorox wipes. Really, soap and water is the best thing for this virus. This virus has a fatty envelope around it, and soap cuts through that fatty envelope and makes it where the virus cannot survive at all. So good old-fashioned soap and water is great. If soap and water is not available, you can use alcohol-based sanitizer. Cover your coughs and sneezes. Be careful about leaving droplets on surfaces. So that's using a tissue or your upper sleeve if you have to. Avoid touching your face. That includes your eyes, your nose, your mouth, especially if you're out in public, if you're at the grocery store, if you're using some type of mass transportation, if you're around people and touching surfaces that they've been at. Very common for us to touch a surface and then touch our face and bring this virus back to us. And don't share food, drinks, and personal items. So the other thing is to keep away from people. And this is really hard to do. We're a very social culture. But even people that aren't sick can shed the virus before they get symptoms. So they may not know that they're going to be sick. They may not look sick. You may not know that they're going to be sick. But they can shed the virus for several days before they develop any symptoms. So even if your friends, family members, etc., say, I'm well, we really have to be careful as we can to avoid unnecessary contact with other individuals. And it's really hard for us to do, but until this dies down, it's the thing that's probably going to make the largest difference in us preventing the spread of COVID-19. Wash items coming into your house. If you have to go out, don't shake hands, kiss, or hug. Use some other kind of greeting. And we've all kind of been joking about the other greetings we can do. You can bow, wave, you can nod, but stay 6 feet away from people if you can. Consider wearing a mask if you can't stay 6 feet away from people. If you're going into a crowded grocery store or something like that, where you know you're going to be in close contact, a mask, whether that's a routine surgical mask, whether that's a homemade cloth mask, whether that's a bandana, something just to help protect yourself there. And then the other thing for right now is stay home as much as possible. And we'll talk a little bit more about what this social distancing and flatten the curve means and how we're doing with it and the impacts that we've made. So what to do if you feel unwell? Don't go out in public. Seek medical attention. Let a doctor know your symptoms. A lot of patients are able just to stay home and to ride this virus out like they would a flu or a cold. If you don't need to go to the hospital, stay home and minimize contact with people. If you do need to seek medical care, oftentimes you can call ahead, whether that's your doctor's office, whether that's the emergency room. A lot of times they have special procedures for people that think they may have COVID-19 to help get you the care that you need and also avoid exposing a lot of other people. So they may have special instructions about an entrance or even a drive-through testing facility that they'd like you to go to. So, are cancer patients at increased risk? The answer to this is really complex, but the answer is yes. So, they are at increased risk, but not all cancer patients or survivors are at the same type of risk. Several reports have indicated that people with comorbidities, other medical problems, have higher complication rates with COVID-19. This includes diabetes, hypertension or high blood pressure, lung conditions like asthma or pulmonary fibrosis, and cancers. So, what should cancer patients do? Should they stop therapy? Should they defer therapy? Should they proceed ahead? There's a lot of questions out there. So, the leading comorbidities among COVID-19 deaths in New York, here you can see hypertension. Now, you have to be careful about how you interpret these graphs. So, is hypertension more dangerous than diabetes or more dangerous than cancer? No, it's just that hypertension or high blood pressure is very common in Americans. So, again, 86% of New York State's COVID-19 death have involved at least one comorbidity. But if you look at this list, COPD, cancer, heart failure, high cholesterol, coronary artery disease, hypertension, diabetes, these are things that most people might have one of. So yes, cancer is on this list, but again, you can see that less than 10% of the state's deaths were patients that had cancer. This just came out on April the 8th in the Lancet. And this was an article looking at COVID-19 in a multi-center study and looking at patients with cancer to see whether they are more vulnerable to side effects and complications of COVID-19. And the answer was yes. So if you see this underlined part, mainly these were patients, about 233 hospitalized patients without cancer, 105 hospitalized patients with cancer. So already we have a little bit of a bias because these were people that were sick enough that they needed to be hospitalized. Some patients were at home and we don't know about them, okay? So what they looked at was 4 different outcomes: death, admission to an ICU or a critical care unit, development of severe symptoms, or needing to be on a ventilator or a machine to help you breathe. And they looked at patients that had cancer, different types of cancer patients that were a different part of their journey versus patients without cancer. And COVID-19 patients with cancer did have higher risk in all 4 outcomes. But it wasn't equal across all cancers. So patients with blood cancers or hematologic cancers like myeloma, lymphoma, leukemia, patients with lung cancer, patients with metastatic or incurable cancer, they had the highest frequency of severe events. Non-metastatic cancer patients with cancer stage 1 to 3, really didn't look like they had higher rates of complications than patients without cancer. So I think this is reassuring for those cancer patients. Many of our patients, unfortunately, do have metastatic cancer. And so they are a high-risk population and a population that we have to be very careful with and try to isolate them as much as possible. So this is another publication that just came out this month, and it's the new recommendations for the prioritization, the treatment, and the triage of breast cancer patients during the COVID-19 pandemic. And this was called the COVID-19 Pandemic Breast Cancer Consortium. And so you can see in these little bubbles across my screen the different organizations that went into making these recommendations for us. So the NAPBC, the National Accreditation Program for Breast Cancers, the COC, the Commission on Cancer, the ACR, American College of Radiology, so our imaging experts, the National Comprehensive Cancer Network, or NCCN, and then also the American Society of Breast Surgeons. So the COVID-19 Pandemic Breast Cancer Consortium, they recommended breaking down these categories based on patient condition. So priority A is when they recommend the patient condition is immediately life-threatening and clinically unstable. Priority B is the patient situation's non-critical, but a delay beyond 6 weeks or so could potentially impact their outcome. Or priority C, the patient's condition is stable enough and not risky enough that this couldn't be delayed for the duration of the COVID-19 pandemic. So remember, priority A is, serious, needs to be taken care of now. Priority B is could be delayed a little bit, but not too long. And priority C is could be delayed. And so they broke down some recommendations for different things. So this is outpatient visits. Then we're going to talk about medical oncology, surgery, etc. So again, this is outpatient visits. Priority A, so something that's unstable. You'll see here that a new diagnosis of invasive cancer is priority A. This should proceed ahead. Now, many of us are seeing some new patient consults via telemedicine, so on Skype or on Zoom on our computers. But those patients should not be deferred. We should not be sitting at home waiting for COVID-19 to pass through before we take care of patients with new cancers. Priority B is a new diagnosis of a non-invasive cancer. In the breast cancer world, this is ductal carcinoma in situ, or DCIS, where it's a little bit of a pre-cancer lesion, not immediately life-threatening. Or established patients with symptoms or new problems, a lot of those we're also converting to telemedicine visits if possible. But again, not something we want to push off for very long. Priority C, survivorship visits. Patients that just have a high risk for cancer but no current cancer. So a BRCA mutation visit. Or patients with surveillance. So right now we're pushing out of a lot of mammograms. Priorities for breast imaging. So priority B, mammogram screening when we know that there's an abnormality, etc. You see over here on the right, priority C, that we should probably defer until COVID-19 is over, is routine screening for mammograms. So if it's about to be time for your yearly April mammogram, yes, that's okay for us to defer a little bit right now during COVID-19. But if you have a known abnormality in your breast, if you feel a lump, or this was recommended follow-up from already an abnormal imaging test, this is not something we should be deferring. So this is a much more complicated slide. This is priorities for medical oncology. And I put a little bit of it over here to the right, but I tried to summarize it on the left-hand side of the screen for you too. So priority A, do not delay. Do not delay neoadjuvant or adjuvant chemotherapy for triple negative or for HER2 positive breast cancers. Do not delay early line curative intent chemotherapy to improve outcomes. Do not delay chemotherapy that is for metastatic disease when people are early in their disease course. Do not delay curative chemotherapy that's already been initiated, meaning patients should continue to complete their recommended course of chemotherapy. Also, do not delay endocrine therapy, so tamoxifen, aromatase inhibitors, etc., or the LHRH agonists to put people into menopause so their endocrine therapy works well. All of these are known to improve outcomes for people that have cancer, and they should not be delayed. Priority B, a several-week delay may be okay. So we might be able to use neoadjuvant endocrine therapy to delay surgery for some stage 1 breast cancers. This is not appropriate for everyone. So again, this is a conversation that you would have with your individual doctor. We could also consider shorter durations of adjuvant trastuzumab for patients that are HER2 positive. We had some studies in the past couple of years that indicated that completing 6 months of trastuzumab may not be that much worse than a full year. And so in certain cities, most not all cities across the United States, but certain cities like perhaps New York, where there's a lot of COVID-19 right now, it could be reasonable to have that conversation with your provider about whether cutting the adjuvant trastuzumab duration short by a couple months would make sense for you. And then palliative chemotherapy in the later line. Again, this is a very individualized decision and is not appropriate for all patients. So priority C, consider delaying. Bone agents for maintenance. This is denosumab, zoledronic acid. It's not going to hurt the bones for us to take a couple months off from this. Follow-up imaging for surveillance. So if you get breast MRIs alternating with mammograms every 6 months and we need to push one of those out by a couple of months, that's okay. So priorities for breast surgery. So A and B should not have significant delays. patients with infection, patients that have just finished their neoadjuvant chemotherapy and need to go to surgery to get the tumor out, triple negative and HER2 positive patients, patients with larger tumors, or any patients with node positive tumors that are estrogen receptor positive. Expander placements, those can go on as scheduled as well. Priority C, consider delay, excision of benign lesions, prophylactic surgeries in people that don't have active cancer, ductal carcinoma in situ, so a non-invasive precancer lesion, or tumors that are responding well to neoadjuvant hormonal therapy for stage 1 breast cancers. So a lot of people are asking, what's the impact on clinical trials? So some trials have been postponed due to logistical resources, challenges, and issues, not only from a supply standpoint, but ability to monitor patients on these drugs and get drugs where they need to go. I'll tell you that the majority of trials remain open, and the vast majority of our metastatic incurable disease trials do continue. I'm actively seeing new patients here at Sarah Cannon in Nashville, and we're actively enrolling patients onto new therapies. So my and Sarah Cannon and HCA take is that cancer is not optional, nor is it elective. And we will do everything in our power to keep care uninterrupted, and we'll be here to care for our patients. So where do we stand in our communities? Where do we stand in Tennessee? And I think it's really confusing watching the news and seeing the media. You hear one report that, oh my gosh, this is so much better. It's not nearly as big deal as we thought it was going to be. And then the next news article you read is that it's horrible and it's only going to get worse, and it can be very scary. And so here are the actual facts and the numbers. So right now we've had 4,362 confirmed cases in Tennessee, and this was as of April the 8th. We've had 79 confirmed deaths, 449 hospitalization, over 56,000 people have been tested, and there's almost 600 people that have already recovered from their disease. Okay. So yes, there are definitely a lot of COVID-19 in Tennessee, about over 4,000 cases. Certainly not as high as a state like New York. And then over here on the right, you can see these yellow bars are each day how many new cases we've had. And the blue line is the increase, so total cases reported. And again, you see this blue line now up here about 4,362. But as you can see, there were higher yellow bars back at the end of March, and the yellow bars now are a little bit lower. So that's because of all these instituted methods that we've done, social isolation, keeping non-essential employees at home, closing businesses that don't need to be open, kids being out of school, being very cautious about being in groups, stores only allowing a certain number of people in, so the density of people in the store is lower. So all of these are working. The fact that we're staying at home and we're being socially isolated is working. It doesn't mean that we blew this out of proportion and this didn't need to be done. It means that we knew it needed to be done, we're doing it, and it's working. So what about Georgia? So you can see here the light kind of, I don't know, maybe bone white color is up to 300 cases per county. And you really see that it's Fulton County up on the top and the surrounding counties right around Georgia that have a lot of cases. And then there's also one county further south that has quite a bit of cases. You can see the total number of confirmed cases in Georgia is higher than Tennessee. It's 10,000 cases right now. Hospitalized cases, about 2,000, and deaths, 379. So you can also see a little bit from looking at these numbers. We know that there are over 10,000 people in Georgia that have COVID-19. Most of these patients are not hospitalized. About 20% of them are. Okay, so 80% of people are doing fine at home riding this virus out. 20% of people are hospitalized. And in Georgia, there's been a little bit higher death rate than some places. It's very dependent, and it looks like it's also a lot of dependent on age of the population. So some places where people that are getting it are younger may do better, and people that are older may do a little bit worse. So how have the projected number of deaths evolved? I think this is a nice graph to look at. So even back on April the 2nd, not too long ago, you remember number of March, we were talking about thousands, perhaps even a million Americans dying, and this has substantially changed. So as of April the 2nd, the estimate here was 93,000, then down to 81,000, down to 60,000. And again, this is the University of Washington's data. So flattening the curve or doing social isolation, all of us trying to stay away from people that we don't need contact with and stay home as much as possible, is changing the number of people that will die of this. It's working. So I think, a lot of people's questions in summary really are, what does this mean for me? So I think what this means for you is to be wise about what you're doing, about how much you're getting out, how many stores you're needing to go to. Some people may be able to get grocery delivery. Some people may need to go to the stores to get their groceries. Some people may have friends or family members that'll bring their groceries if they have cancer. Also, to stay at home, to see whether working from home is an option. And then also what to do with your individual therapies. So really there's no one size fits all cookie cutter answer for this. This really needs to be an individual conversation between you and your provider. But I think it's clear from the emerging data that patients that are survivors that may be on an aromatase inhibitor or endocrine therapy for their breast cancer or who had chemotherapy years ago probably are at not a very high increased risk compared to average patients. But patients that are on chemotherapy, might have lung cancer, hematologic cancers, et cetera, probably are at higher risk. And we need to be very careful to isolate those patients as much as possible and use as many precautions as we can. Here in Nashville, Tennessee, we are actually screening all of our patients that come into the clinic with temperatures and also questions about whether they've been sick, whether they've had cough, shortness of breath, any fever at home. Unfortunately, and this is sad for a lot of people, we've needed to limit visitors in the exam rooms and the treatment room just because we don't want to expose our patients to any more people than we have to. And so some of these measures really are making a difference. And so I encourage you, if you have questions about your individual care or your risk or what you should or should not be doing at home, to reach out to your provider. I'm certainly talking to people about this in clinic. For patients that aren't coming into the clinic or we're trying to keep at home, we're setting up telemedicine visits or a good old fashioned phone call to talk to them about this and what their risk is and what we would recommend. So I would encourage you to have that conversation with your doctor. Again, thank you so much for joining me on behalf of Sarah Cannon Research Institute and also Komen Central Tennessee.